All right, what's up, everyone? Happy Wednesday. We are going to get started on some stuff that's super high yield, but we don't really cover it anywhere else. Things like heart sounds, things like lung sounds, things like positions. Positions we do cover a little bit in the on-demand and in the live course. However, not as many as I would like to cover. We're starting to see these a lot more on the board exams. You're going to see it throughout school. Those of you that are still in school, those of you that are taking your board exams, PN, RN, it doesn't make a difference. You're going to need to know it. You're going to need to know it for real life. So these are lessons that should be learned and kept with you moving forward. So before we get into that, we do have an individual that made it to the other side. We started limiting it to about 1 to 2 interviews. We have so many people that want to participate in the interviews, but unfortunately, it cuts into our lecture time. So I want to make sure that we're getting the most out of these lectures because today's lecture is pretty intense, it's heavy, a lot of great information, some new tables and things of that nature. So with that said, let us find our first. And Nurse Amika, I hope I said that right. One second, let me stop sharing. There we go. All right, where are you at?
Hi.
Hi. So do you like to go by your last name, which is what I called you, or do you like to go by your first name?
My first name.
Okay, and I didn't want to butcher it, so would you be so kind as to pronounce it for me?
Ngazi.
Ngazi. Okay, perfect. All right, Nurse Ngazi. So we are on the other side. Congrats, first and foremost.
Thank
So
you.
what of NCLEX High Yield did you use?
So I used the May course, I believe. And then I did like the free weekly Zooms.
Okay.
And then I listened to some podcasts. So I tried to
Okay.
get into as much as I could.
Yeah,
Yeah.
absolutely. So with the May course, we took it this year, the May course
Yeah.
in 2024.
So I did the live course. And then I took my NCLEX in July.
So May to June, basically about a month after the live course, you were able to take your exam and you passed. Now here we are on the
Yeah.
other side.
Yeah.
So you use the live course podcast, the weekly Zooms. How many questions were you?
85.
85 and out. I mean,
Yes.
if this isn't a trend, this isn't a trend. I can't begin to emphasize how many students are constantly getting 85 and out. Again, I always say going with the mentality of 150, that's what I prepare you for. But
Mhm.
150 or 85, a license is a license. So we're not
Yeah.
worried about it.
Yeah.
What attempt was this for you?
I'm sorry, say that again.
What attempt was this for you?
Oh, this is my first.
First, one and done,
Yeah.
85 and out. What made you invest into NCLEX High Yield?
So I actually had a friend that graduated from the same school I went to, and then
Okay.
she told me all about you, and I was like, okay, I definitely have to like buy like the subscriptions and everything because I felt like my nursing school, I was just like studying to pass. I wasn't studying to like retain the information. And I
Right.
felt like with you, like the classes, like the on demand, it was giving me the content that I needed. And I felt like I learned so much more than my years in
In
nursing
school.
school.
Yeah.
So like she told me about like the on demand, like how you have like so much content, and I was like, yeah, I definitely have to get this because I know that that's what I was lacking in, like knowing the content. So
Right.
yeah.
Well, there you go. We say it all the time. Look, when you're in nursing school, it's great because you're doing section by section by section by section. You take your final, you move on. However, the cumulative comprehension that you need to be able to pass this board exam is so different than what you learn in nursing school. And the
Yeah.
approach to a board exam is so different. Obviously, you've been through the course, one of our more recent courses as well, too. So you've gotten the most updated notes, the most updated lectures, so on and so forth. What is
Mhm.
your advice, Nurse Ngazi, for students that are currently trying to pass or on the other side?
So I would say reviewing your notes every day because I actually only watched like all the on demand videos once. But then what helped me was like every day I'll watch every single like I'll read every single notes that I took the previous day. And I just kept doing that just to retain all the information. And it wasn't even like I was cramming the information because I felt like your videos made me like really understand stuff. So it was just kind of like a review every day just to like keep the information fresh in my head. And I felt like that's what really helped me.
Right.
So just yeah, keeping your brain familiar with the information.
Yeah, absolutely. I say it all the time. We need to do something NCLEX related every single day.
Yeah.
And that commitment, I tell people all the time that, I speak to students all the time, and I've got students, that have been out of school for X amount of years. And
Hmm.
I go, look, if you're going to look at the amount of time or how many attempts you've taken, and you're out for 1 year, 2 years, 3 years, average that out to anywhere from 70,000 to 100,000 a year. Like every year that you've lost that income. And to hesitate to invest in yourself, which is what you did. You didn't even think twice about it. You invested. Here we are, one and done, 85 and out within a couple of months, and you were ready
Yeah.
to start making that money back. Boom. Like
Yes. Yeah.
so with that said, Nurse Ngazi, thank you so much. I think Nurse Brittany's gonna reach out to you because we'd love to know what school you went to, but you don't have to,
Yeah.
let us know here. But Nurse Brittany's gonna reach out to you and let us know what school you were with, and we'd love to help anybody with schools out here. We love to help those students out as well too. So, with that said, thank you so much for sharing your journey. Thank you for being a part of us and letting us
You.
be a part of your journey as well too.
Thank you.
You're very welcome. Take care.
Bye.
Bye. So, with that said, we've got again another pass, 85 and out. Those of you that have been with me week by week by week, very important to understand that we are not aiming for 85 and out. We're aiming for a pass because the license is a license. However, the trend is being set. You're seeing student after student after student getting 85 and out, 100 and something out, even 115 out. It doesn't make a difference. But again, the takeaway is invest in yourself. This is your future because when I see students that are taking 1, 2, 3, 5, 6, 7, 8 years, I'm like, listen, you've lost $250,000 to maybe even $1 million in income, and you're worried about spending 449. It doesn't make sense. Just kind of put things into perspective. It's a drop in the bucket when you're talking about the grand scheme of things. So make sure that we are knowing what we're losing as opposed to what we're going to be spending. And I'm not saying to spend on us. By all means, I'm not out here trying to promote, hey, use, Dr. Z and NCLEX High Yield. Find what works for you. There's so many great programs out there, but find what works for you and invest in yourself. Again, doesn't have to be with us, but do it because again, every year, not only the fails, not only the ATT that you're spending on, not only the lost income and the defeat and that whole mental anguish that you're going through, the anxiety, the overwhelming, the constantly having to answer to your peers and to your family and to your friends, all that goes away when you invest in yourself. So don't hesitate. Again, 70, 80, 90, 100 plus $1,000 a year every time you take a year to pass an exam, even 45 days, you're talking about six, seven, eight, $9,000. Just know that this is what's happening every time we fail or every time we hesitate. We do offer financial or we do offer payment plans if other places don't as well too. But another way to get great free resources, we have a financial assistant letter. I'm probably gonna be making a YouTube or a podcast here or both, talking about the different ways where you can get money as far as helping you get through this exam. So financial assistant letters, you reach out to community organizations, religious organizations, even your job, keep your invoice with us. We'll provide you an invoice so that way you can take it and ask them, hey, look, will you reimburse me? If they're willing to sign you and give you a job, they're probably willing to pay for your reimburse you for your actual course or tutoring or whatever you did. Our tutoring is available. I did open up. I had a lot of people reach out to me saying that Dr. Z, will you do one-on-ones? And same with my nurses, they're available. So I do have 6 hours available, only 6 hours. They sell out real quick. With mine, you're going to get direct access to me, just like you do with other nurses. So having direct access to me, to my personal email, is something that a lot of students like to have because you check in with me until you pass directly, not in any other way. I do create practice questions for you, brand new practice questions on subjects that you want to learn on your own. And we'll go through practice questions and study whatever you want to study as well. And I give you a PDF of everything as well as my other tutors as well too. My price is a little bit more expensive and my availability is limited, but we have wonderful tutors, every one of which that has been in your situation, in your position. So make sure that you're looking out for that if you need some one-on-one tutoring. Of course, free, 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 our favorite four-letter word aside from pass. First one is pass, second one is free, and they're probably equivalent at this point. So anything that's free or that's going to lead to a pass, definitely utilize our free resources, podcasts, Instagram, YouTube, Facebook, all of the above. If you're not subscribed to our YouTube, subscribe now. Very important self-paced course for those that want the notes, that want the 70 hours plus. We're offering that as well too. It is on special. And then our August live course is on early bird special right now. Those are the links to those if you need them. Our course is, the live course is a little bit different than the on-demand. One, you'll get 90 days of access to the on-demand. Two, you'll be able to check in with myself or my staff, not directly like you do with one-on-one tutoring, but through a different portal. The other thing is that there's specific lectures that are in the live course that are not in the on-demand. They're made to cater to the people that invested a little bit extra, that want that live course, that want the student forum or the group me where they can communicate with other students. We do make practice questions specifically for the course, brand new practice questions as well too. So you can do that as well. $449 right now while the early bird is there. We have a 30-day flash sale on the on-demand, and then 3-hour tutoring packages. I think these are sold out. Sorry, these are sold out. Correct, Nurse Brittany? I believe we are sold out of that. Yeah, we are sold out. We just have an individual. NHY 10 is the discount for boot camp for those of you that want the boot camp QBank. Nurse Brittany will put a link into the chat. You can save 10%. So 10% is better than nothing. I was able to negotiate. UWorld doesn't help me. Archer doesn't help my students. So you know what? We went with boot camp. They were willing to give our students 10% off. Better than nothing. So there is group study tomorrow, August 15th. Again, group study is just for you to get an advantage over everyone else. Everything that I'm giving you is an advantage over everyone else. So if you want that $34.99 for about 90 minutes plus of me doing practice questions, lecturing topics that you want to cover, I'm doing that tomorrow. It is close to being sold out as well too. And you will get a PDF of practice questions as well out of that, so you can practice that as well. We are doing another trivia night. How many people joined us for trivia night? Yeah, I see. Nurse, I hope I said it right, Nostalgia or Thalgia. I hope I said it right. But yeah, we are definitely enjoying. Trivia night was a hit. This time, we're going to allow everyone to participate. The top 3 are going to get an NHY box. It's got T-shirts, it's got cups, it's got pens, stickers, all our books, calendar, abbreviation, quick tip, cardio book. It's got everything in there. You just let us know what size. We ship it out to you. You get a whole nice little box. Top 3 will win. Top 3. Everyone is invited. The best way to pass your Friday night, those of you that were there, firing those neurons and making those connections, total different way of learning. So again, with my background in teaching from Stanford School of Medicine, it was one of the things that I learned was make those neurons fire. So again, it was super fun. We had a blast. Everyone was enjoying. This time, everyone will be able to participate. Those that come in on time. Yeah, it was a lot of fun. Make sure you join. With that said, let's get started. So I'm going to cover 3 topics. This may be a part 1 and a part 2 lecture. This may be a part 1 or a part 2 lecture. The thing about the topics I'm going to talk about is heart sounds, lung sounds, and positions. Now, let's think about how the boards are going to ask it. One, if I'm looking for a heart sound, I'm probably going to look for it to be diagnostic of something. If I'm looking at a lung sound, I'm looking for it to be diagnostic of something. If I have a heart sound and a diagnosis with it, what type of a question is it? Diagnostic, education, farm, treatment. These are all what? They're freebie questions. Either you know it or you don't. Those that don't know the 5 types of questions, it is arguably one of the biggest things that I've discovered up there with ASCRAF, ASH, NIPA, needs, all these things that I've come up with that nobody else has discovered. 5 types of questions, whether it be next gen or traditional, know them. I cannot emphasize that enough. So there are 4 heart sounds that we can that we need to look at. I'm going to cover the first 3: S1, S2, S3. S4 I don't find to be high yield. I'll probably come back to that in part 2, but I want to get through some of the high yield ones first. So what is an S1 sound? What is an S2 sound? Those are your typical heart sounds. They are the closure of certain valves, also known as your lub-dub, lub-dub, lub-dub. S1, lub, S2, dub, lub-dub, lub-dub. Every time you hear or auscultate a patient, you should hear that S1, S2, S1, S2, S1, S2. What is causing that to happen? So let's understand exactly what's happening here. And as you all know, this is how I make my heart. And this is our lung. In our heart, we've got between the atrium and the ventricle, we've got valves. What we have, what we have is a tricuspid valve between the right atrium and right ventricle. And on our left, so tri-right, that's kind of, remember, tri-right, right, right. And mitral is left. So this is your bicuspid or tricuspid. What happens is our blood flows from the atrium to the ventricle. And as the ventricle contracts, these valves snap shut. The mitral and tricuspid valve snap shut as the ventricle contracts. Boom, snap shut. So as they snap shut, they make that lub sound, or our S1. Then we've got a pulmonic valve and our aortic valve. When the blood has released out of the ventricle and these snap shut, we get our S2 or our dub sound. That's normal. Remember, I always start with normal before I go into any pathology. So that is normal. We've got our tricuspid on the right, 3 leaflets, 3 leaflets between the right atrium and the right ventricle. Between the left atrium and left ventricle, we get the mitral, emphasis on the L, left, and it's a bicuspid, meaning there's 2 cusps. As the blood flows down through the atrium into the ventricle is going to start to contract to open up that pulmonic valve or that aortic valve. And as that blood flows out, this will snap shut. The mitral and tricuspid valve snap shut. Boom. You got your S1. You got your S1. That is your lub. As the pulmonic and aortic valve snap shut, you've got your dub. That is your S2. That is your S2. So again, as we've got written here, and we're going to post these tables. Nurse Brittany, correct me if I'm wrong. We're going to post these on Instagram?
Yes. Yep.
Instagram, Facebook, our VIP Facebook group. So if you're not in any of those, we'll put the link into those as well. So again, we've got the closure of your mitral and tricuspid valves, and then we've also got the closure of your aortic and pulmonic valves. So the closure of the valves is what causes that boom, that sound. Where are we going to hear them? Where are we going to hear them? Where we're going to hear them is described as a freebie question. These are easy points that you can obtain, whether it be in school or whether it be on the boards. They're easy points. A patient is being auscultated for heart sounds. The patient or the nurse is expected to find the S1 sound at what location? Do you think that's a freebie question? 100% it is. It's a freebie question, which means that, can I describe it to you? Best heard at the, and this is exactly how I would write it, best heard at the apex of the heart. So if I was to draw my heart at an angle, where's the apex located? at the point, at the bottom. The base, don't use the word base, because the base of the heart is actually up here. So don't use the word base. They will confuse you. So knowing your terminology is very important. The base of the heart is actually up here. The apex of the heart is actually at the bottom, where it comes to a kind of a, I like to think of it as a point. If you look at a normal heart, anterior posterior, AP. So now at the apex of the heart, can I list that as a freebie question? Straightforward. Patient, again, like I said, practice question. If I make a question up, you should be writing that down, because I'm thinking of these questions off the top of my head. I've got some practice questions here as we progress, but I'm thinking about that off the top of my head. I'm like, wait a minute, I can ask a straightforward question. A patient is, or a nurse is auscultating a patient. Where should the S1 sound be heard? And boom, I'll put base of the heart, apex of the heart, right sternal border, left sternal border. Which one are you going to choose? I just gave you 4 options. Do you think you need to know all of those locations, anatomical locations? 100% you do. Because that's real life and that's board. Freebie question. Don't miss out on it. Now we're looking at the fact that we've got the apex of the heart. Cool. All right. Do you think I can give you a hot spot? Yes. Yes. How many people saw hot spots on their exam that have taken the exam where they showed you where to auscultate either an S1 or ape to man, your aortic, pulmonic, tricuspid, mitral, rubs? How many people saw a hot spot like that? Maybe even in Q banks. Yeah, I've seen them everywhere in all types of ways, whether it be descriptive or it be actual hotspot and identifying. That's S1. However, if we get a loud S1, we may be having what's called mitral stenosis. Mitral stenosis. So let's go back to our heart. Mitral stenosis, where are we going to find all our mitral sounds? Somebody tell me. Oops, sorry, ape to, this is herbs. Ape to man. So where are all our tricuspid or mitral sounds? There are at our 5th intercostal space, and then our mitral is mid-clavicular. Again, easy points. Mitral stenosis. So what does that mean? Our mitral valve is stenosed. So if I have a loud S1, if it's stenosed, it's going to take a lot of pressure for that mitral valve to open. If it's stenosed, that means that all this blood is trying to get through a narrow and stiff mitral valve, and it's trying to open. And as it gets open, boom, it snaps back shut because it's narrowed. So it takes a lot more pressure. As that pressure pushes that stenosed valve through, boom, it snaps back shut. So I get a loud S1. A loud S1. If I have a soft S1, what's happening in a soft S1 is it's not snapping shut completely. It's kind of doing one of these, which means that I may have, instead of that hard pressure with stenosis, it's actually the opposite, where I'm having blood regurgitate. Is it going to be able to snap shut and make a nice S1? No, because that blood going backwards through the valve is going to kind of keep it from snapping shut. It's going to make it kind of go like this because blood is kind of coming through. So it's not going to completely snap shut. It's going to kind of like slowly close. So you get to soft S2. Mitral stenosis, push, boom, snap shut, loud. That's stenosis. It's trying to get through. Boom. As it snaps shut, it's loud. Normal, blood from the atrium to the ventricle, close this. Normal, dub, or lub dub sound. Normal, lub. Normal, S1. With mitral regurgitation, there's blood going through, so it's not going to snap shut. It's going to close like that. That's the difference between a loud S1, mitral stenosis, a normal S1, and a soft S1, where we have regurgitation and it's not snapping shut as powerful as it usually does. So again, there's multiple ways of asking this. Soft S1. So just because you see S1, don't automatically go to it being normal. Look and see if they're describing it as loud, mitral stenosis. Look at it as being soft, mitral regurgitation. Look and see if it's where they're asking to auscultate your S1. We're going to be able to see it at the apex of the heart. So again, if I've got regurgitation in the left side of the heart, if I've got regurgitation in the left side of the heart, I've got maybe a valve that is compromised. What are some things that can cause valve compromise? We talked about this in our cardio section on demand and in our live lecture. We talk about what? We talk about endocarditis, right? We talk about the inflammation or infection in the heart. And now we've got the valve that's starting to get weakened. Mitral stenosis, now we've got weakening or we've got a compromised valve, which means that my left side is going to have the inability to perform as my body needs. So what is it going to do? Work harder, work harder, work harder, work harder until it does what? It fails. So we're always looking for heart failure. Now I've given you a case study. Think about this. Here's a question. Just write down case study in your notes, put a colon, and say case study. In the case study, I'm giving you a physical exam, and on auscultation, I hear a soft S1. I will probably, in a case study, even give you that I've heard a mitral regurgitation, and I'm looking at that as a fifth intercostal space mid-clavicularly. I hear a murmur. And now I've got a patient who is now cold and clammy. Oh, let's take it back, right? Take it back. Cold and clammy, low oxygen, pallor, left-sided heart failure, right? Now we've got that JVD, pulmonary edema, pink frothy sputum, excuse me. So again, we've got to be very careful in these patients. That's your S1. Your S2 is the aortic and pulmonic valve. This is going to be at the base of the heart. And again, do you see how the term base, you think base meaning the bottom. But in fact, in comparison to the apex of the heart and the base of the heart, it is in fact, the apex is here where the base is up here. So now we're able to hear this at the base of the heart. And what we're looking for is a wide or a fixed splitting of the S2, which means that I'm hearing, how many S2s am I hearing? If I've got a pathological situation, this is not a normal, I'm hearing a wide or a fixed splitting. So am I hearing lub dub or am I hearing lub dub dub? Lub dub dub. Lub dub dub. Wait, lub dub. Lub dub dub. Lub dub dub. I'm confusing myself. Lub dub dub. Lub dub dub. So, and you will hear this as you practice, you're going to hear these sounds. And hearing it as silly as it sounds, lub dub, lub dub, lub dub. You can hear it, lub dub dub. Yeah, I feel like I'm saying three dubs for some reason. Lub dub dub, right? So now we've got fixed splitting, which means that one is closing later than the other. Just think about it. We've got two valves that close to make one sound, the aortic and the pulmonic. Ventricles contract, boom, goes out the pulmonic valve. It goes out the aortic valve. They close, they make an S2, normal, dub. But now we've got a splitting or a wide S2, meaning I'm going dub, 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 which means one is closing later than the other. More times than not, it's going to be the pulmonic valve that closes later than the aortic valve. Why? Because we can develop pathologies of the lung. So let's think about this. We've got our lung, and then we've got our aorta. We've got our aortic valve. And then over here, we've got our pulmonic valve. Now, going out the aorta, no big deal, right? We're able to contract that left ventricle, push out the aortic valve. But what if we have some sort of pathology with the lung? What if we have pulmonary hypertension, meaning I've got high pressure in that pulmonary system, and trying to get blood through that high pressure, it's going to have to work harder against that pressure, which means that I'm going to keep that valve a little bit open a little bit longer because I've got to go against the pressure. Whereas this one, it just goes right out. And now as it's trying to go through that because of that pulmonary hypertension, how about restrictive lung disease? Things that we've talked about in respiratory. In this situation, it's taking a lot longer for me to get through and a lot more work for my right ventricle to push through against that stiff, hardened lung, that restrictive lung disease, that pulmonary fibrosis, things like asbestos, sarcoidosis, things like foreign substances, people that work in nuclear test sites, people that work in chip plants that are inhaling constant things that are scarring our lungs. And now it's not as compliant as it used to be. Now it's stiff, it's hardened, and now we're trying to go against that hypertension, that pulmonary hypertension. And I have to work, my right ventricle's got to work harder, which keeps that pulmonary or pulmonic valve, it keeps that pulmonic valve open longer, which means my aortic valve closes S2. And then finally, my pulmonic valve closes S2. So now we got that dub, dub. Dub 1, dub 2, dub, 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 dub. We got a fixed or a wide splitting S2, which means my right ventricle is pushing harder. That's why that pulmonic valve is opened for a longer period of time and not closing the same time as our aortic valve, which means that we're getting a second S2 sound. But if that right ventricle is pushing against that pulmonary hypertension, restricted lung, fibrosed lung, scarred lung, how about a drug that causes pulmonary fibrosis? How about a cardiac drug that causes pulmonary fibrosis? How about amiodarone, PFTs, LFTs, TFTs? Throwing a little farm right there. Amiodarone could be the cause as well too. So now my right ventricle is working. What's eventually going to happen? Is fibrosis reversible? Is that stiffening hard lung? No, it's not. It's not. So any of the restrictive lung disease, pulmonary hypertension, drugs like amiodarone that fibrose our lungs can cause that stiff and hard lung, and that's not going to reverse. It's irreversible. So now we've got this right ventricle going and pushing against that pressure. It's going to push and work harder and harder. until it does what? It sits there and it fails. And so now we've got what type of heart failure that I'm looking out for in a wide or fixed splitting S2, right-sided heart failure, right-sided heart failure, because the right is going to work hard, and then eventually it's going to fail. Know your signs and symptoms of right-sided heart failure. So you see how much I'm tying in here just by giving you one description. Great case study, great case study. And now what am I going to do in a matrix or a grid on that same case study? Compare what? Right-sided to left-sided to complete heart failure. There's your matrix or grid right there. Signs and symptoms, education. So again, very important. Super, super complex heart sounds. People get very confused. They miss easy points. So if you're feeling a little bit confused, it's okay. It's okay. Just make sure that you're learning these a little bit more in depth, because they are, in case studies, they're going to give you these things. They're going to give you these things, right? Soft, loud, S1, wide or fixed splitting, S2. You need to know what they mean. You need to know what they can lead to and take it that step further. It's not just about saying, oh, they've got it. Well, what does it mean? Oh, they've got elevated white blood cells. Well, what does it mean? What type of white blood cells? What do you think it indicates? This is the way that the boards are going. And rightfully so. We should all know these things. As medical professionals, we should all know these things, right? S3 is the third heart sound. So I'll go S1, S2, S3. S1, S2, S3. S1, S2, S3. It kind of sounds like a gallop, like a horse. Do you hear that? It's not lub dub dub. It's, do you see? It's a gallop. It's a gallop. What's happening here is that we need to understand when it's okay and when it's not okay. So in children, young adults, you hear that, no big deal, right? Can we investigate a little bit more? Sure, why not? If we feel that it's something that there's other signs and symptoms that we're concerned about. But as far as an S3 being a pathological issue, where we're looking at the pathology of an S3, we're looking at adults over 40, sorry. We're looking at adults over 40. And what's happening here is we're looking at things like heart failure again, but why? Why is an S3? Why does an S3 occur? Well, in heart failure, what happens in heart failure? Does the heart contract as we want it to contract? No. Our heart is not contracting in heart failure like it wants to contract. In heart failure, we're actually starting to get a buildup of this fluid into the ventricles. And as blood goes down through the valves, they're going to hit that fluid. You're going to hit that fluid. So as we try to contract, as this closes, we're going to have blood hitting that fluid. And it causes that fluid that's gathered in the ventricle, because it cannot get out. We've got heart failure, right-sided, left-sided, complete. It doesn't make a difference. We've got heart failure. So we're not able to empty out the ventricles as we want. And now, as fluid hits that fluid, we're getting this vibration. And now what we're getting is an S3. So S3 is going to indicate to us that we've got fluid overload or heart failure. Or heart failure. So S3, we have to investigate in patients over 40. Are they going to be accompanied by signs and symptoms? Yes. Are we going to get a BNP? Yes. Is this the same as an MI? No. If you don't know the difference between a myocardial infarction and heart failure, I can guarantee you the boards are going to try to confuse you, whether it be cardiac enzymes or lab values, signs and symptoms, the risk factors, the causes, the treatment. It's all very different. Don't confuse them. Don't confuse them. That is your S3. So again, you need to identify the S3, know that this patient is above a certain age and or has signs and symptoms, know what to do about it. And again, what are we going to identify? Heart failure. And we're going to administer diuretics. In all heart failure, diuretics, yes. In all heart failure, BNP, yes. In all heart failure, daily weights, electrolytes, fluid balance, yes, yes, yes. In all heart failure. Signs and symptoms are going to differ, but the treatment for heart failure, the S3 for heart failure, is all going to be the same. Cold and clammy in each one, yeah. Of course, blood's not getting out. Paler, pallor, yes, of course, blood's not getting out. But again, these heart sounds are so important. What should you take away from what I just taught you? You must understand the pathology. You must understand the difference between a loud S1 or a soft S1, the wide or fixed splitting, why that's happening, and the pathology of an S3. But they're going to be freebie questions, but I can take it way, way, way further. I'm not going to get into S4 today, but I will get into the other two. Murmurs. Again, a murmur is that blood flow across a valve, or, and we can add this into the notes here, or we can have some sort of a anatomical defect. What are two anatomical defects that I'm looking at between the ventricles or the atrium that can occur? Anatomical defect, an atrial septal defect, or a ventricular septal defect. Atrial septal defect or a ventricular septal defect. So now we can have issues with the valves, aortic, pulmonic, mitral, tricuspid. And we can also have it as an anatomical defect, ASD or VSD, where our septum is not connected, or we have a quote unquote hole in the heart. And as that flows back and forth, whether it squeezes through or it's stenosed, or it's regurgitation and it flows backwards, or it's connected between the septum in an atrial septal defect or a ventricular septal defect, either ways, we're having blood flow going across a place where it should not be going through. And in each situation, we're going to hear a murmur. And this is where that ape to man, aortic, pulmonic, herbs, tricuspid, and mitral are so important to identify, whether I describe it or whether I give you a hot spot. How am I going to further investigate this? Here's a perfect board question. Which of the following actions should the nurse expect to do in a patient that has any of the above? Mitral stenosis, mitral regurg, aortic stenosis, ASD, VSD, a septal defect. What is going to be one of the diagnostic tests that we're looking at? Echocardiogram. What is an echo? It's just an ultrasound. And it's going to show us the way that the blood flows up and down through the valves, side to side, if it's a septal defect, because the septum is between the right side and the left side of the heart. So very important that we understand what a murmur is. There is one that sticks out to me that is specific and it's descriptive. I talk about this ad nauseum. It is a machine-like murmur, harsh machine-like murmur, continuous machine-like murmur, a loud machine-like murmur, and boom, you see everyone putting it in the chat. PDA, PDA, PDA. Now we're going to talk about a pericardial friction rub. Around the heart, we've got the pericardium. And now we've got some sort of fluid built up between the pericardium and the heart. Around the heart, we've got fluid buildup, and this is called pericarditis. We have some sort of fluid around the heart. And what that's going to cause is that's going to cause us to have a friction rub. We're going to feel this, we're going to hear this friction rub. And they may decide, or they may describe this as a grating sound. If you hear the word grating sound, or if you see the word grating sound, this is kind of like a squeaking noise. It's like a squeaking noise. So that fluid around the heart is causing that friction rub. So we're worried about this pericarditis because if I hear that, you will not get me to do that again. But if you hear that squeaking noise, that is a pericardial friction rub. Where do we hear that at? We hear that at Erb's point, third intercostal space on the left sternal border. Third intercostal space at the left sternal border. Again, ape to man know those anatomical locations. Because the problem when I hear this squeaking noise, you think this patient's going to have chest pain? 100%. But that pericarditis can turn into a more emergent situation, which is a cardiac tamponade. And you must know Beck's triad, JVD, muffled or distant heart sounds, and low blood pressure, because that fluid around the heart is squeezing in on the heart, and now that heart is stuck. It's stuck. And now you've heard, before it turned into a tamponade, when it was just the pericarditis, you heard that friction rub, that squeaking, that grating sound. That shows up, you're being proactive because we want to get that inflammation down. So those are the heart sounds that I want to talk about. Let's do some practice questions here. I'm going to get into, I didn't even get into lung sounds. This is going to be a part 2 for sure, because lung sounds are definitely important. So let's do this. We use the method. Considering the pathology associated with the soft S1, a soft S1, boom, which means something's keeping it from closing, snapped shut. Which condition is the patient most likely experiencing? What type of a question is this? I told you, these are easy questions if you know what they're looking for. You know how many people don't know what a soft S1 indicates, and now you do? This is 100% either you know it or you don't. So this person here that thinks heart sounds aren't important is going to miss this question, and it is a freebie question. So a nurse auscultates a patient's heart. Here's a soft S1. Is it a right bundle branch blanc? No. Is it pulmonary hypertension? No. Which one is this going to be? That S2, that's going to be wide or fixed, splitting, right? Now we know. Mitral regurgitation, yeah, because if I'm going back through that mitral valve, it's not going to snap shut. I've got this blood going back up that's keeping it from actually snapping shut. It's just going to slowly close. It does a soft S1. Mitral stenosis, it goes through and then boom, it snaps shut. Mitral stenosis, boom, and it snaps shut because I got to push, and it snaps back harder. So again, very important that we understand that the loud S1, I put that there. I gave that as an option. That mitral regurgitation, which is the correct answer, pulmonary hypertension, where I put the S2 in there, you see how there are so many different ways where I can ask this, but I guarantee you a good majority of people would not have known what a soft S1 means. But now we understand that there's blood going back and it's not going to snap shut and make a nice lub sound It's not stenose where it makes a loud one. There's blood going back through, so it's gonna do a soft one. Everyone with me on this? Does that make sense? Are we starting to understand and apply? Love it, love it, love it. So again, our rationale is provided here as well too. Brand new lecture, brand new questions, brand new tables, brand new notes all together. Stuff that I don't talk about again, but we're starting to see, because a lot of people are unfortunately missing these points because they're not taught properly. I watched, just as a little tangent, I watched a couple of different things that I find we do our due diligence, and if we're incorrect on something, please bring it to our attention, because we are by far away from being arrogant or thinking that we're know-it-alls. So I saw somebody that was teaching the RAAS, and they were like, it's the renin angiotensinogen system. This person has hundreds of thousands of followers, and I was like, wait a minute, you're teaching this incorrectly. It's the renin angiotensin aldosterone system. You're skipping aldosterone, one of the biggest parts of the RAAS. I saw somebody that taught PVD incorrectly as a venous disease. It's not. It's an umbrella term. I saw somebody that said, choose chicken breast if you see it. It's not always correct. I see these things and people are getting taught incorrectly. So make sure you do your due diligence on who's teaching you what and what their credentials are. So please, please, please make sure you know that. So now, which condition is most likely associated with this finding? Again, what type of a question is this? It is 100% a freebie question. A freebie question. So now we've got a patient during cardiac assessment that is where the nurse detects a split S2 sound at the base of the heart. Again, remember, the base of the heart is up here. The apex is down here. So again, S2, split sound. So what are we thinking is happening here? Well, what's happening is that for some reason, that pulmonic valve and that aortic valve are not closing at the same time, which means that one of these, more than likely, I said is probably the pulmonic valve, is going to close later because it's split, or it's a lub-dub-dub. Lub-dub-dub. Which means that this is the first dub, this is the second dub, because something is keeping this open longer. And if I've got blood flowing from the atrial septal defect, meaning it's going from the left atrium back to the right atrium, down to the right ventricle, I'm getting more blood flow to keep that pulmonic valve open a little bit longer than this aortic valve. That fluid is going backwards into the right atrium, down to the right ventricle, and keeping that pulmonic valve open longer than it takes for this aortic valve to shut. So we get that splitting of the S2. S2 is pulmonic valve and aortic valve closing at the same time. Lub-dub, lub-dub. But now we've got extra blood from the left atrium through this atrial septal defect, going back towards the right atrium, down to the right ventricle, and pushing that pulmonic valve open a lot longer, or not a lot longer, significantly enough longer to hear a split between the dub sound. Now it's lub, dub, dub, lub, dub, dub, lub, dub, dub. So again, knowing that this is what's causing it, the splitting of the aortic and pulmonic valve is what's causing that split or wide S2 sound. Freebie question. Freebie question. So now when you see split or fixed or widened, you're talking about what? Some sort of issue with blood getting into the pulmonic and through the pulmonic valve, or extra fluid coming back, causing that pulmonic valve to be what? Split. Split. ASD, BSD, I'll take it. All right. What should the nurse monitor for in this patient? A nurse hears an S3 sound during auscultation of a 55-year-old patient with a history of hypertension. S3 sound, 55 years old, hypertension. So what are we concerned about? What are we going to monitor? Simple. We're looking for what? I told you that S3 sound is going to be indicative of potential heart failure. So aortic stenosis or heart failure, such as edema and dyspnea. Well, if I hear that S3, 55-year-old hypertension, I'm looking at signs of heart failure. Left ventricular hypertrophy, and this is actually your S4, but we'll talk about that at another time. But again, heart failure, I told you, we've got too much fluid left over in the heart that's failed us. So we're getting that S3, that gallop. A nurse hears S3 heart, again, 55-year-old. Is this indicative of or do we need to monitor for dehydration and electrolyte imbalances? No, in fact, this person is going to be what? They're going to be in a fluid overload situation. They're retaining fluid. They're not able to get rid of it. They're not able to get rid of it. So yes, again, straightforward, straightforward, straightforward. Let's see if we can squeeze in one more. We'll skip this one because we didn't do S4. Let's see if I got one more. Ooh, we don't. I'm not going to get into this, but I'll give you a preview of what's to come. So lung sounds, vesicular, bronchial crackles or rails, wheezes, bronchi stridor, pleural friction rub. Don't mix those up with pericardial friction rub, absent or diminished. And then as we get into positions, we'll get into Fowler's, semi-Fowler's, high Fowler's, supine prone, lateral, Sims, Trendelenburg, lateral decubitus, lithotomy, knee to chest, and the different ways we see tripod position. So a lot of different high yield topics coming up, especially next week as we continue this lecture. So again, with that said, I do hope that everyone was able to enjoy today's lecture. It was brand new notes. We're going to post some of these things as they come about. So make sure that you're here next week. If you enjoyed this, brand new questions, brand new tables, brand new topics, you already know what I want. I just want those cameras on, cameras on, cameras on. And all I want is everybody waving because here we go. Let's try that one more time. Here we go. What's up, everyone? Dr. Zeeshan here. Check it out. We are here at a free weekly Zoom. We covered heart sounds, S1, S2, S3. We talked about fixed and wide splitting S2. We talked about soft and loud S1s, all the pathologies, all the signs and symptoms that come with it, because all these beautiful people here that are waving at you, waving at you, waving at you, getting their free education on are here doing this because guess what? If you are not here on a Wednesday, what is you doing until next week? See y'all then. Take care. So with that said, if I offended anybody, I apologize. If we can get better or made any mistakes, please let us know and we will correct them and we'll work on getting better. And all we ask in return is please post about us anywhere to get the hype up. The only way we can continue to do this is if we get a lot of people going. Otherwise, they're going to yank this from me, and I love doing this for free. So please spread it, whether it be a Facebook group, Instagram, Reddit, anywhere that you can. Spread the word, get people involved in it. The more people that we get, the more I can continue doing this. If we don't get enough participants, we cannot continue doing this. They're going to yank it from me, and I don't want to do that. And then also remember trivia night, Friday night, 5 p.m. Pacific Standard Time, 8 p.m. Eastern Standard Time. It's free for everyone, come and enjoy, enter to win a prize and just get those neurons firing. It's a lot of fun. I'll see y'all next time. Take care.